My guest today is Professor Daniel Appelbaum, who is Professor of Radiology and the Director of the Nuclear Medicine and PET Imaging at the University of Chicago. Welcome, Dan.
Thanks for having me.
Yeah, thanks for doing this. So I know that we have sort of two broad areas we want to go into. One is in the area of nuclear medicine, and the other is radiomics more generally. Could you, to set the context, could you sort of talk a little bit about what nuclear medicine is and how radiomics fit into that arena?
Absolutely. So yeah, it's a little confusing. I'm kind of wear multiple hats. Some of them overlap. I'm a professor of radiology. I'm a board certified radiologist. But my area of expertise is within nuclear medicine. Some people calling that molecular imaging now, which is not just imaging, it's actually also more and more therapy. And so I guess, a basic starter issue that a lot of people have questions about is, what is nuclear medicine, molecular imaging, versus, conventional radiology. And so radiology is medical imaging, and things that you've been familiar with would be, a chest X-ray, other types of X-rays, MRI, ultrasound, CAT scans. But all these modalities have somewhat in common, paint with a broad brush, they use a machine which has a external energy source, whether it's radio waves and magnets with an MRI, or an X-ray source outside the patient with a plain film, an X-ray or a CAT scan, sound waves with ultrasound. But these are all external sources of energy, including radiation, that get passed through the patient. Nuclear medicine is kind of the opposite of that. We make the patient the energy source. We make the patient radioactive. We inject them with a radioisotope, depending on what we're looking for, and we have dozens to pick from. And the patient literally becomes radioactive, and the patient is emitting the X-rays, which can then be detected on an imaging detecting device. Either way, whether it's an external energy source or the patient is the energy source, we make a medical image that is then read by a radiologist or nuclear medicine physician. So that's kind of the one main difference, how the images are acquired. And the other main difference is that the radiology images, again, MRI, CAT scan, ultrasound, X-ray, they tend to focus on anatomy. Okay, you see a bone that has a crack in it. You see a shadow in the lung, a nodule, because it's there. Something abnormal is sitting there. So that's anatomy. Nuclear medicine, molecular imaging, is imaging physiology, how things are acting, how they're actually functioning. And so, we can see a fracture, but we don't see the crack in the bone. We see the bone next to the fracture healing. We see the healing process. We can see a nodule in a lung, but not because it's there, not the anatomy, but what it's doing. Is it eating lots of sugar, and maybe it's a lung cancer, or does it have a large number of special receptors, and it's a carcinoid tumor, for example. And so we're seeing physiology versus anatomy. A lot of people call nuclear medicine unclear medicine, make fun of it, because the images are almost necessarily kind of a little muddy. Physiology is a fuzzier process than anatomy. But more and more, but these are, on the other hand, very powerful images. So they're kind of fuzzier, but very powerful. But more and more, we're actually combining the two modalities into one machine. And so we have a PET CT machine or a PET MR machine, and we can have the best of both worlds to show both the physiology and the anatomy all on a single image with lots of powerful information.
So Dan, just at a very high level, is it correct to think about nuclear medicine, you put some sort of a radioactive tracer into the body. It can travel inside the body. It can go to a target, and then you can really sort of see at a molecular level what might be happening. Whereas radiology in general is more about large structures with, as you say, as a source from outside, right? The resolution you get is not necessarily very high, I would think.
Yeah, so you're right. A nuclear image, you inject a radio tracer and it goes to its intended target. And it's showing on a molecular level what's going on, whereas radiology is showing the anatomy. Radiology has much better resolution. So, I mean, the idea of large structures, I'm not sure is the best analogy. But it's looking. You're correct in that it's looking for these molecular processes, which we can image, and more as we can talk about, with Theranostics, we can inject other radio tracers that deliver different kind of radiation to the tumor, for example, and actually can treat it. So maybe the most common nuclear study these days, if you got to pick a single one, is a FDG PET scan. You may have heard of a PET scan, and we use it for a number of different reasons, but the most common is to detect cancer. And it's elegant, in some ways very simple. The tracer that we usually use is simply a radioactive sugar. We inject a radioactive sugar called fluorodeoxyglucose, and cancers use more sugar than normal tissue, a lot more sugar most of the time, and the sugar will go to the tumor and all its locations. It will then give off the X-rays, and we can take a picture of that. And we can detect areas of cancer that perhaps were not seen on the CAT scan or the MRI or the ultrasound, because we can detect things at a molecular level and often at a much smaller level, actually. Then we can turn around and give a different kind of radiation, a much more powerful radiation, and target the tumor in a similar way. But instead of taking a picture of it, we can fry it and actually treat the tumor, and only the tumor. You don't get hair loss, you don't lose your stomach lining and get nauseous and throw up. You don't usually even feel it inside of you, but we're actually treating the tumor, for example.
So this is a lot more precision targeting, right? So you can go to the site and you can make an impact at the site more precisely. But once the tracer is in there, do you have any control over it? I know that there's a lot going on with micro robotics and delivering medicines directly to certain sites. Is there, once the tracer is inside, do you have any control as to when to fire or not to fire?
So these tracers are developed over many years. We use rats and other animal models and see where they go. But once we have a very clear idea where they're going, we use them in humans. We know exactly where they're going, and where it's being excreted. Most things are leave the patient either through the urine or the feces, or sometimes both. So the way these work is they go to their intended targets. It sticks there. A portion of the tracer will stick there. The rest of it will get excreted from the body. That's one important factor. But the other one is whatever we're injecting does not stay radioactive indefinitely. They all have what we call a half-life. How long does it take for half the radioactivity to actually no longer be radioactive or decay into a non-radioactive state? And so,
what's a typical half-life of?
So the most common tracer we use with PET has a 2-hour half-life, 118 minutes actually. So you're looking for a sweet spot of a tracer that stays radioactive enough for you to inject, for it to localize in the patient, for you to take your pictures, but then to decay away and no longer be radioactive. So, after about 10 half-lives, the amount of decay is very, very minimal in a patient. So after 24 hours, the patient is really no longer has detectable radioactivity within them. Now, some tracers we give, they might be have a half-life of over a week, like iodine-131. And the patient might be radioactive for weeks. In fact, sometimes we'll give them a letter that they carry around with them, and we say you need to carry this for actually a couple months, because in this day of Homeland Security now we have radiation detectors at airports, and the Sears Tower, now known as the Willis Tower, for example, and you can actually set those off, and they can produce their letter, and they'll give us a call just to make sure they're not holding a dirty bomb. So, but most tracers, and when they're radioactive for a longer period of time, we're forced to give a lower amount of radiation to the patient, if that makes sense. But so that's how we control. We don't control it, but we've observed what it does, and we predict, and we can know exactly how the radiation is going to act in the patient.
Yeah, I was reading through one of the review papers you had sent, Dan, and it's about Theranostics. It says it refers to the pairing of diagnostic biomarkers with therapeutic agents that share a specific target in disease cells or tissues. And so it's sort of going in, and it's getting information to actually do a diagnosis and then treat. So how does the technology work in that context?
Yeah. So, we're entering a very exciting period in molecular medicine, where the scientific reality of our capabilities are finally catching up with the theory and what we dreamed about decades ago, and we're just starting now to see all these different tracers come and almost become available to market. Some of them are still in like late research trials, and there's many more in the pipeline. But as I alluded to earlier, we can give a tracer to take a picture, and we can give a tracer to treat. And so the interesting and exciting model that's kind of come out recently has kind of taken those two terms, diagnosis, to identify, and therapy, and made the word Theranostics. And but more importantly than the word, of course, is the what it's describing, and that is a tracer which will demonstrate whether a tumor is avid for it, and it will light up. And then you can use, so you have let's say, and I'll use let's say you have a prostate cancer, and most prostate cancers, or much of the prostate cancers, have a certain antibody on them called prostate-specific, an antigen called prostate-specific membrane antigen. And we can take an antibody to this antigen, and we can first put a diagnostic isotope on it, like F18, and see, is the tumor taking up this? Does the tumor have these receptors? Does it have this antigen? Is it taking up the tracer? We take a picture of that, and we say, hey, look, it's lighting up. It's lighting up. We can say then, great, now let's swap out the diagnostic energy source, the diagnostic radiation that just gives off photons for pictures, and let's put a more powerful radiation source on the same exact antibody, because we've now proven that the tumor of this particular patient contains this antibody, antigen, and we can put on, say, a beta emitter or an alpha emitter. These are more powerful forms of radiation that don't actually leave the patient. They don't make it to the detector for a picture, but they stay. They travel less than a millimeter, and they can actually fry the tumor, again, without the patient even being aware that anything's going on inside them. And so you take the same diagnostic tracer, make sure the tumor lights up, and then give a different flavor of the same tracer and then treat it.
Yeah, that's really interesting. So sort of a two-stage process. So you put in a sort of a low radiation tracer in, and you can take some images. If things are lighting up, let's say it's pancreatic cancer, then you conclude that it is actually cancerous. And then you take the second step in terms of it's the same route in terms of treatment, same route, but this time it has sufficient radiation capabilities to actually fry the cancer cells.
Yeah, a different kind. So the type of radiation that we link on to take a picture, they're gamma. It's called gamma radiation. Gives off gamma rays or X-rays. Doesn't fry things, but it just allows us to take a picture, and then we swap it out with a beta or an alpha particle to allow us to.
And I would imagine in the diagnostic phase, do you get some measurements as to, is there some optimization in terms of how much radiation would be optimum given I don't know what the right term would be, but given the scope of the cancer?
Right. So that's a very good question. And there's different approaches, and we're still kind of, at the early phases, and we're kind of learning. So some of the therapies that we give have kind of a standard dose. We're going to give this to every patient. Others are very per patient, although it's somewhat crude. It's like weight based. You can say per kilogram of weight, we're going to give this much radiation. But there are different ways to, in what you are describing, is to quantify the actual tumor uptake. There are ways to do that. They are complicated and time consuming, but we can certainly do them, and we do that on specific cases. But we're still kind of learning, what's the right dose. There's a lot of different variability. Each patient will respond differently. Each tumor will respond differently. But yes, so the different options would be, standard dose to everybody, weight-based dose, or then try to be a more quantitative per patient, which you would think would work the best, and it probably will. And this is what people are working on right now, and we're kind of working our way through.
Yeah. I mean, cancer is obviously the most challenging disease. They say every person is different, every person's cancer is different. And so there is really no commonality in terms of what a cancer might be, right?
That's true. I mean, exactly. When you mentioned personalized medicine, I mean, a long time ago, you had breast cancer or you didn't, but everyone got treated the same with breast cancer. And then not that long ago, they said, hey, we can subdivide breast cancer into those that are estrogen receptor positive or progesterone receptor positive or HER2 receptor positive. Now we have like 3 kinds of breast cancer. But guess what? There's probably, dozens or scores or more, and each patient might have a slightly different mutation that we can take advantage of. Each patient's cancer may have a slightly different mutation that we can take advantage of, and we want to personalize it per patient. The problem is, well, of course, working through all these different types and figuring out what works best. But cancer is very sneaky, and it can be very variable within a single patient, and that's what we're seeing now with PET imaging. We see, we might know the patient has 50 lesions from a CAT scan, but only half of them are lighting up on a PET scan with this tracer, and the other half on this tracer, and so you can't treat all of them with the same therapy, for example, and then the cancer will mutate, and that's why it's so hard to treat and to cure, is because there's many different kinds, and they're kind of a moving target, even within a single patient, even within a single organ within a single patient. Different liver metastases might have different biology from each other and act differently, but that's where personalized medicine is heading.
And I guess it's changing with time too, right? As you mentioned, the cancer is mutating as well. And so what you expect to see today could be different tomorrow.
Absolutely, yes.
So that makes it a challenging arena. You have another review article. This is about radiomics. You say radiomics has the potential to play a pivotal role in oncological translational imaging, particularly in cancer detection, prognosis, prediction, and response to therapy evaluation. And the paper talks about all sorts of different cancers. And so, what is sort of the state of the art in radiology in terms of detection and prognosis prediction?
Yeah, so I mean, computers are taking over the world, including medicine and including imaging and radiology and molecular imaging. Hopefully not completely taking over the world. But so like every other area, computers are making rapid inroads into, how we operate and have become a real important piece of the puzzle, and increasingly so. And so, radiomics is a relatively new term, but it basically it's part of this whole computer-aided diagnosis, artificial intelligence that applies not just to nuclear molecular imaging, but like you said, all of radiology, to all of medicine. But in terms of radiology and radiomics, it's looking at features on the image that might not be appreciable to the radiologist, using a computer to kind of, it's almost like putting, there's different ways to kind of define it and to approach it, and has different kinds of aspects to it. But, right now when I'm looking at a CAT scan, I see a nodule, and I say, yeah, there's a nodule there and it needs to be biopsied. But what if we could put the edge of the nodule under a microscope and look at the interface between the nodule and the normal lung, and what's the sine curve of the degree of spiculation or scalloping along that margin in a very fine detail level that no eye could see. Does that predict how this lesion, what this lesion is, how this lesion acts, what this lesion needs, what's the prognosis, what's the treatment? So that's just one example of many different features. You could then say, well, let's look in the center of the nodule and see how it's, some areas are denser and some areas are not as dense. And so by looking at these types of features and seeing, what did this turn out to be? How did the patient do? Putting this in a database and comparing it to many different patients' nodules with similar different features. So trying to extract these features that, again, we either can't detect or weren't thinking about. And then you can go on and just let the computers, run wild with deep learning, and kind of, so we can try to train the computer, but the computer can then, if you give it enough data, it can train itself. And what it finds is sometimes very surprising and almost, nonsensical. There was a study where, they had the computer analyze all sorts of mammograms, and to see if it could detect, which patients had cancer, which cancers did better or worse. And, it found lots of things that we were expecting, that one would expect, but then it found if the shoulder blades of the patient were elevated, the patient was going to do better or worse. They might die sooner. What does it have to do with anything, the shoulder blades? Well, it turns out that when you do a mammogram, you have to hug the machine, and if you're flexible or you're not flexible, your shoulder blades are going to be elevated or not. And the non-flexible patients were older and more sick and likely to die from other causes. And so it finds these things that are actual and real, but are completely kind of out of left field. Some of them are useful and some of them are. I've gone a little bit into left field with the question.
No. That's a really interesting area. So, I mean, the beauty of machine learning, as you know, is that it can take large amounts of data. I would imagine an experienced radiologist ultimately creates a set of heuristics from experience, when he or she is reading that image to reach a conclusion. But there's those heuristics, we can't really reveal those because it's essentially experience-based heuristics. So the radiologist say, I can tell you, but I can, I can put this down in equations to precisely reach a conclusion. Whereas if you have all those features extracted, machine learning techniques could be deployed on that. And there are two types of techniques, as you know. One is called supervised machine learning, which is basically saying, suppose I give the machine images of cancer and images of benign tumor, and so I have two sets of data there, and let the machine sort of learn from that, so it can assign a probability of a new one that is given. My understanding, Dan, is I don't know, I haven't seen this lately, but I have heard that mammograms machines have gotten to about 4% error rate now, and that is actually a little better than humans. But perhaps mammograms are easier, I don't know, but machines seem to have done pretty well there.
Yeah, so mammograms were one of the very first areas where computer-aided diagnosis was, I think it was the first FDA-approved area. In fact, at the University of Chicago, where I am, we were instrumental in that process. But yes, the thing about computers and machine learning, that they're very good at doing several tasks, very focused tasks. Mammography is a very focused task. You're almost always simply just looking for one thing: a breast cancer in a breast or not. But as you said, machines aren't perfect. They're very, very good. And people always ask, are they going to be replacing radiologists in jobs? And I think the answer is no. One way to think about it is that if you have two radiologists reading the same image, they've done studies where if you have two mammographers reading the mammograms, they're going to do a little bit better. They're going to find a little bit more cancer. They're going to have more accurate diagnoses slightly. It's way too expensive for any institution to do that. But if one of the readers could be a computer and then kind of compare notes, that would be, it's just kind of a simplistic example, but that's an example. You can think of it as a spell checker. Say, hey, this is what I think. Did you notice this? What do you think about this thing over here? Oh, thank you. I didn't see that. No, I think that's okay, but I can see why that would bother you. Or, yes, you know what? I did not notice that, and you're absolutely right, computer. That's a suspicious lesion. And so, again, kind of simple examples, but in computers, there's no doubt they're going to get more and more sophisticated. But it's kind of like the self-driving cars. You want, they can do amazingly well, but then they can make incredibly bad mistakes that a human would never make. And so you have to find that right balance and the kind of hybrid methodology of using computers, what they're good at, but being able to kind of override their boneheadedness sometimes, or just different way of approaching the universe.
Yeah, it's sort of computer-enhanced human decision-making, right, at the end of the day. There is, I would imagine, scope for, sort of exception-based management. What I mean is that suppose we have a deep learning trained network that can assign a probability that something is cancerous. And if that probability is extremely high, perhaps the decision is somewhat obvious. But if it is like 55-45, let's say, that's not that useful from a decision-making perspective. And that's something that the human really needs to get involved in, something along those lines, perhaps.
Sure. Yeah, that's a good example of one thing the computer can say, yeah, I'm sure of these, I'm not sure of these, and that would be more for the radiologist. It could look at all these studies in advance and say, if you have a board full of CAT scans to read, and you're just reading them in the order they popped up, but if the computer could be looking at them in advance and saying, hey, I think there's something really important, not a cancer, but like, a stroke about to happen or a big bleed in the head, you want to read this one first. Put it to the top of your list of 50. There's so many different ways a computer can enhance radiologists' workflow, accuracy, timeliness, all of these things.
Yeah. And the other area is, as you know, is unsupervised machine learning. And I think, that example that you gave in terms of people hugging the machine, less flexible and more flexible. So even without labeled data, you can let the machine sort of, here's a bunch of images. Can you put those images into buckets, into sort of look for patterns in those images? Basically, we're reaching a stage that computing time is getting less and less expensive, right? So you could let the machine just sit there, look at this data almost on a continuous basis, and it might actually come up with some insights that might take a human, a long time, and that's very expensive from a human resource perspective, I would think.
Yeah, no, absolutely. That's certainly one of the many ways that could be a big.
Yeah. So as you look forward, Dan, in this area, in the review paper, it talks about all the different types of cancers, where this sort of machine learning approaches could be applied from a diagnostic perspective. And so I know the technology is really advancing in radiology too. So you look forward 4 or 5 years, where do you think you will be? Are there some sort of new technologies that are coming through that is making these images much more, maybe higher resolution, more readable? I don't know what the right terminology might be, but there are new technologies in the horizon?
There's always new technologies on the horizon. 4 years, I'm not, I love the old saying, and I find it to be pretty true that especially with computers, we tend to overestimate what we're gonna accomplish or change in 3 or 4 years, and yet underestimate, in 10 to 15 years the changes. But as far, so the field has become pretty mature as far as the imaging side. I feel we saw great growth in the last 20 years. Kind of like television, right? We made the jump from analog to digital, and then to high definition. With 4K, with regular high definition, and now 4K. Now they're talking about 8 and 16K, but it's really kind of diminishing returns at this point, I feel. And so we've made some great strides with CAT scanning and MR, and in PET scanning. A couple of years ago, the digital PET scanners first started coming out, and they're wonderful. But and I hate to predict this, and maybe I'll be wrong, but from a hardware standpoint, I think we're at least in nuclear, we're not going to. I don't see any huge leaps going forward, but where we do see the leaps are in the new tracers that are being developed, and that's been a huge, as I mentioned, robust area of growth every couple months now. We used to get one new tracer a decade, and now we're getting one or more a year. It seems like every couple of months there's a new tracer being successfully, forget about in the research pipeline. I mean, there's dozens of those, but actually brought to market, approved by the FDA, commercially reimbursed, being manufactured and distributed and used in routine use in patients. So I think we're going to continue to see lots more of these tracers, both for diagnosing disease, and for treating them. And the computers are going to continue to progress. I mean, that's not mature. I think that's going to, if anything, will continue to go. People talk about the singularity, but it can exponentially increase in the power and the use of the computers. So I don't know. Maybe in 10 years we're going to be seeing a lot more of this deep learning computer assistance and diagnostics, and lots more of these tracers, which will now have a lot more time to to kind of utilize and have experience with to see, where they fit in with this whole idea of personalized medicine and molecular imaging and treatment. So yeah, it's a very exciting time and field.
Do you think we might reach a position that, just like mammograms now, that we reduce the cost of these scanning and diagnosis substantially to lower? We reach a point that maybe you do sort of a whole body scan on a routine basis. I don't know what routine, maybe once a year or something. And it's not necessarily human looking at all this data. All this data is pumped to a computer, and the computer can assign some sort of a probability that something needs to be looked at. Do you think we might get to something like that in the future?
It's possible. People have been talking about this for a while now. I mean, you walk into the ER and you just get a scan, and you see what's going on, or like you said, just as part of your annual your checkup. I mean, we have been reducing the amount of radiation you need to get a good picture in those areas of radiology that use radiation, like CAT scans and nuclear, like PET scans. And then, of course, there's radiology tools that images that use no radiation, like ultrasound or MRI, full body MRI. The problem is they're still, they're still expensive. And even though the cost is coming down and they're time consuming, those that use radiation, even a low dose, it does slightly increase one's risk for things like, cancer down the line. Number one. Maybe the bigger problem, though, is we still have a problem of overdiagnosing. So we haven't really talked about this, but once you take a picture, and you often will find something, just a nodule or a cyst or something that, if you hadn't taken a picture of it, it's a benign thing or a very indolent thing, never would have bothered the patient. But you have to prove that and go through all sorts of steps, other tests, biopsies, and these other tests are expensive and time consuming and can actually end up causing complications and hurt the patient. And so that's a big problem. And even more than that, even trickier than that is even something that we find incidentally, like on one of these scans, some of them are actual cancers, but there are also cancer. There's cancer and there's cancer, and we're finding that some small little cancers, like small thyroid cancers, or even some breast or prostate cancers. Yeah, if you would have lived to 500, they would have turned into something bad. But right now, they wouldn't have bothered you. And so, even when we find a cancer now, we're not sure all the time what to do with it, depending on where it is and how big it is. These questions will continue to get sorted out. Again, not in 5 years, probably not in 10 years, but in maybe 20 to 40 year range. We'll have it's a process. We'll have a better understanding of these types of things. But to answer your question, no, I don't see, even though it would help, it would be good for the field of radiology as far as financially. I don't see it happening as far as just whole body scanning for an annual checkup, unless you're at a really high risk. Now we do this, of course, with certain areas of mammograms. All women should be getting annual mammograms starting at a certain age, and if you have a certain genetic mutation that puts you at a high risk, you should be getting it even more frequently and more advanced imaging like MRI. And so this is an example of personalized medicine, and we'll continue to see this kind of develop and blossom. But as far as like just your average person coming in getting a scan, probably not for quite some time.
Yeah, so as you said, there's a real trade-off there, right? I read somewhere that, I don't know if it's true, anybody above 70 has some sort of cancer somewhere, and they're not going to die of that cancer. They're going to die of something else because they're not aggressive forms of cancer. So once once we go in and start to treat all of these things, just the lifestyle and the utility from doing that declines quite dramatically, right? So I guess that's a real trade-off in terms of as technology improves. I was just thinking as we were talking, as you walk through that scanner in the airport, and there's intelligence built into it, and basically says you may have to, go to talk to a doctor.
Right.
I mean,
Well,
privacy concerns.
we're patients with these like Fitbits or Apple watches that will measure your EKG. At least a crude example of it. I have a number of every once or twice a month we get a patient into the cardiac clinic, and the history is Apple Watch or similar detected a arrhythmia, and that's what started the whole thing. So yeah, it's not so far fetched that these things will start to play a role. And then I talked about living to only going to live to 100. Well, that's a whole other discussion with someone smarter and more expert than me about the parallel advances we're making in longevity and anti-aging, genetic modifications and all sorts of stuff, and being able to live to 150 or 200 or beyond. That's probably coming, maybe again not in 10 years, unfortunately, but so it opens up all these other questions. We're living longer. We're going to get more cancers, and it's kind of an arms race between all these different factors.
Yeah, it's a truly multidisciplinary area, right? And so I want to ask you in conclusion, because you're also involved in education. So as students, think about this arena as a possible career. I mean, there is information technology there. We talked about artificial intelligence, imaging techniques, diagnostics, nuclear medicine, truly multidisciplinary area. What would be your sort of advice to students who might consider this arena as a possible choice?
Yeah, I mean, the last time I checked, I think people have been a little scared off. People have made some people in the field have made some comments that radiologists will be out of work in 10 years, and we're actually seeing nationwide. Again, I haven't checked last couple of months, but there was a downturn in applications to these areas. I suspect that's going to turn around, because once people realize that that all these that first of all, the computers are not going to take our jobs; they're going to enhance our jobs. And number two, as molecular personalized medicine continues to grow, and radiology and nuclear medicine and molecular imaging and plays a larger and larger role in the diagnosis and therapy. I think it's going to become even more popular maybe than it was in its heyday in the past. I mean, we're still plenty of people are going into radiology and nuclear medicine, but the numbers were a little bit down recently. But again, I suspect they're going to start turning back up, because it's a great area and it's only going to continue to get better.
Yeah, I mean, especially if you have an interest in both on the computer side as well as on the medical side, this seems like a fantastic area to get into.
Absolutely, yep. There's something for everybody. There's interventional procedures, if you like, kind of being more of a hands-on surgical mentality. There's tracer design and development, benchtop science area. And as you said, the whole, our computer interface, the interface we have with computers is probably more than any other type of physician. So if you're interested in that, absolutely, that's an area. So you're right. There's a lot of different things, and probably something for anybody.
Excellent. Yeah, this has been great, Dan. Thanks so much for spending time with me.
Well, thank you. I do appreciate it, and it was very nice to meet you.
Thank you.